We will be, Vaughn, who's just going to, before we get the session started, give you a little bit of etiquette on the session.
Hi, everyone. I'd just like to take a few minutes to discuss some etiquette points. We'd like to remind you that ECHO is a platform founded on respect, and we rely on you guys to keep it a safe and collegial space for learning. If you have any questions, there's a chat box located at the bottom right hand of your screen, and you can put your question in the chat box at any point during the lecture, or you can wait until the Q&A session at the end, and there's going to be an opportunity to use the raise the hand function where you'll be called upon to ask your question. Please mute your microphone when you're not speaking, but then if you are called upon to speak, remember to unmute your microphone. And should you have any IT issues, just send a message to the chat function or via email. Back to you, Monica.
Thank you guys so much. And again, welcome to our Project ECHO lecture series that is brought to you by Vanderbilt University Medical Center and Vanderbilt Institute for Global Health. We're so grateful for them. It's been a wonderful series so far, and we have several sessions still to go. We'd also like to thank the GE Foundation for sponsoring this and bringing this entire lecture series to you. Today's session, we will focus on the management of multi-organ failure and sepsis for COVID-19 patients. And first, we'll hear a lecture from Dr. Kyle Bruns and Dr. Kaitlyn Brennan. And then Dr. Bruns and Dr. Brennan, they are both critical care fellows in the Department of Anesthesiology at Vanderbilt University Medical Center in Nashville, Tennessee in the United States. And then joining for the discussion portion of our session, we also will have join us Dr. Arna Banerjee and Dr. Kimberly Rengel. Dr. Banerjee is an associate professor of anesthesiology, surgery, and medical education, specializing in critical care medicine at Vanderbilt University Medical Center. And Dr. Rengel is an assistant professor in the Division of Critical Care Medicine, also at Vanderbilt University Medical Center. During the lecture, at any time, if you have questions, we ask that you please put those questions into the chat box, and we will have an extensive question and answer session after the lecture is over. So once again, thank you all for joining us, and I'll turn it over to you, Dr. Bruns.
Great, thank you, Sherry, for the introduction. In addition to the presenters that Sherry has introduced, I'd also like to recognize Dr. John Tarpley for his guidance in creating this presentation, and he joins us this morning. Okay, so before we begin, we do have no disclosures to discuss. We'd also like to point out that this is a very rapidly evolving topic, and that the information that we present today will be based on the current knowledge with the understanding that this may change very quickly. Also, just before we get started, all of the information that you're about to see is a compilation of the current available literature and publications on this topic. It will all be referenced at the end of the lecture. Next slide, please. We plan to discuss the common organ dysfunction and initial treatment in critically ill patients with coronavirus and sepsis, and understand how their organ dysfunction relates to an infectious response within the body, and then we'll formulate an optimal treatment plan based on what your hospital has available. Next slide, please. Typically in the ICU, we approach a patient based on a systems-based approach. So we cover the neurology system, the cardiac system, etc. However, we're going to begin this morning with immunology and allow that to integrate into the other systems. As you're all probably aware, the coronavirus enters the body through the ACE2 receptor, and this is a nice image just highlighting that. Next slide, please. The coronavirus decreases CD4 production within the body. It decreases the function of CD8 and natural killer T cells. It has poor viral clearance in the body, and antibody production is poor as well. These all together stimulate further macrophage activations and uncontrolled loop of self-amplifications. Together, this has been termed the SARS-CoV-2 or COVID-19. In many patients, this is all that happens. Unfortunately, in a select few, it becomes much more aggressive and has been termed a hemophagocytic lymphohistiocytosis, or simply, as we'll refer to it today, an acquired cytokine storm. Next slide, please.
So as Dr. Bruns mentioned, much of the response to COVID-19 centers on this cytokine storm. This can be kind of wide-ranging in many patients. So on the left-hand side of your screen, you see a patient that is not infected with a normal pulmonary epithelium. In the middle would be a patient that has COVID-19 but isn't sick enough probably to require ICU care. So the natural response is to increase pro-inflammatory cytokines like interleukin-6 and also to produce things like TNF-alpha. In some patients, these responses are so upregulated that they develop what's called a cytokine storm. So these large increases in IL-6 lead to lab increases that we'll discuss later, like increases in LDH, D-dimer, and procalcitonin. These patients develop ARDS and respiratory failure and may require ICU care. Could you advance that slide, please? Common clinical manifestations that have been described for COVID-19 patients include fever and cough. These are still the most common things that people present with. However, we found in the USA that there are several other symptoms that our patients are presenting with. We've had patients that present with chest pain and headaches, and older patients especially present with altered mental status. Many patients have GI symptoms like nausea, diarrhea, and there's also a subset that have either a loss of smell or a loss of taste that occurs suddenly. The ACE2 receptor is in both the lower respiratory tract and the small intestines, so it makes sense that these patients have both pulmonary and GI symptoms. Advance that slide, please. Many of these patients will present to either your hospital or to your ICU already in shock. So to manage these patients, we have a couple things that have worked well here and will likely work well for you as well. Dynamic measures for management are very helpful. So for example, using the passive leg raise test can help you to predict fluid responsiveness. So if you raise these patients' legs up, you're going to provide a fluid load basically to the central part of their body. So if their systolic blood pressure raises by 20 points and their diastolic blood pressure raises by 10 points, this patient will probably be responsive to IV fluids, and it would be reasonable to try to give them some fluids to improve their low blood pressure. You can also look at their skin temperature. If your patient has warm skin and their blood pressure is very low, you should be concerned that they have sepsis or some other distributive shock. If, however, they're very cold and clammy and their blood pressure is very low, this should raise the concern for some sort of cardiogenic or hypovolemic shock component. Go ahead and advance that slide. There are some lab measurements that can be very helpful in the initial management of shock. One of those is lactate. If you have the ability to measure lactate reliably and easily, this can be very useful. Elevated lactate is sometimes, and in sepsis, definitely a sign of tissue hypoxia. You can use lactate-directed therapy, so repeated measures of lactate, to guide your treatment for patients. So to guide how much fluid you give them, or to guide adding or increasing your vasopressors. This potentially has the ability to reduce mortality and shorten your patient's ICU stay. If you don't have lactate available to measure, you could use a bicarbonate as a surrogate measure. So a very low bicarbonate level can be used as an alternate marker. If you have transthoracic echo available, this can also help to guide treatment. So basic transthoracic echo views like the parasternal long and short view and an apical 4-chamber view can help to determine whether your patient appears to be volume down or whether they need more fluid or if their ejection fraction appears low. Go ahead and advance that slide.
Now that Dr. Brennan has established what shock looks like in these patients, we'll go into how we can begin treating that shock. So first, starting with fluids. We would recommend using crystalloids rather than colloids. Some examples of the crystalloids that would be helpful: Ringer's lactate, Normasol, or Plasmolite, while we try to avoid the colloids like dextrans and albumins. Normal saline we'd recommend to stay away from. However, if that is all you have available and the patient needs fluid, certainly go ahead and give that. As Dr. Brennan alluded to earlier, a guided fluid approach is appropriate in these patients, so you can use those different measurements that she discussed, like the passive leg raise, the transthoracic echo, and other measurements like this, including laboratory measurements of lactate or bicarbonate. If you've been giving your patient fluid boluses and the patient is still not responsive or not improving, this might be a good time to start using vasopressors, and that's what we'll start next. But before we do that, the only other thing that I want to mention regarding fluids is that if your patient is becoming more hypoxic, this may also be a sign, in addition to your other laboratory measurements and physical exam, that their hypoxia could be worsening and a sign to stop the fluid. Next slide, please. If you've made it to the point of starting vasopressor therapy, norepinephrine is the first line agent that we'd recommend. This is no different than your surviving sepsis guidelines. If, however, your institution doesn't have norepinephrine available, either using epinephrine or vasopressin is a perfectly fine first line option. If your institution does have norepinephrine and you find yourself titrating up the amounts of norepinephrine to achieve a mean arterial pressure greater than 60, then you can add in a second agent, vasopressin. If vasopressin is unavailable, adding in epinephrine works well. One of the pressors that we'd recommend staying away from is dopamine, and that's simply due to its effects with the cardiac system, specifically dysrhythmias. Next slide, please.
It's preferable to run any vasoactive infusions through a central line. However, this may be logistically difficult or just not available. In that case, a large gauge IV, so an 18 gauge IV or larger, preferably in the elbow or the upper arm, can be used safely. Ideally, these vasoactive agents are run through a separate IV pump as well. This is to know exactly what rate we're running and to manage kind of small changes. However, if IV pumps are logistically difficult to obtain or just unavailable, norepinephrine or epinephrine can be added to a whichever size bag of fluid is easily accessible. You can titrate this to effect with things like a roller clamp or a flow regulator. So many flow regulators, like the picture on the left side of the screen, are readily available and can be used to estimate how much pressure you're giving. It's helpful to know how many drops are in a milliliter, and this is on the label of all of your IV fluid sets. This can help you calculate how much pressure you're giving. Ideally, you would use a different IV fluid line for volume resuscitation and other medication administration separate from this pressor line. Go ahead and advance that slide. There's been much discussion of steroid therapy in COVID-19 patients. For patients that present to you in refractory shock and septic shock, the addition of steroids is likely useful and should be considered. For patients that have respiratory failure and ARDS, although there has been some debate, it's also probably helpful to use steroids in this patient. How much steroid? 1 hydrocortisone is preferable, and then 200 milligrams daily is a reasonable dose. This can either be given as an infusion, or if that is logistically difficult to do, it is fine to give it as 50 milligrams of hydrocortisone every 6 hours. That's customarily what we do at Vanderbilt.
Now that we've kind of discussed what shock looks like in these patients and how to treat it, we'll move into the pulmonary system. Some of this may have been previously covered in another lecture, but we'd like to reiterate a few key points. First, when the coronavirus pandemic was getting started, the recommendation was to intubate patients early. We know now that this can actually do more harm than good. So the first thing we want to say is to try and avoid mechanical ventilation if possible. There's a couple different ways you can do that, of course, with supplemental oxygen, but specifically a high flow nasal cannula may be a good first option in patients who are developing hypoxemic respiratory failure. If you don't have a high flow nasal cannula available, you can try a trial of non-invasive positive pressure ventilation. An example of this would be a BiPAP or a CPAP machine. If your patient becomes so hypoxemic that they do necessitate intubation, we would recommend at the time of intubation completing all other anticipated procedures at this time to decrease the amount of exposure to the virus. This might include placing additional IVs, central lines, arterial lines. We would recommend avoiding bronchoscopy or any other aerosolizing procedures. We've discussed how fluids can be important in the shock state, but again, want to reiterate that a conservative or restrictive fluid approach should be taken. When dealing with the respiratory failure, we've found that proning the patient, whether they are intubated or not, tends to help quite a bit. If you've reached a point where your patient is intubated and they are not tolerating the ventilator very well, if there's a lot of patient ventilator dyssynchrony, then using a paralytic may be appropriate. With the coronavirus infection, we have noticed that some patients are also developing a superimposed bacterial pneumonia, so empiric antibiotics may be appropriate. Next slide, please. This is a nice figure from the Society of Critical Care Medicine that highlights a lot of those points. Looking on the left, we start with patients who have developed a mild ARDS, and moving to the right, we see how that can progress to severe and even some recommendations for rescue therapies. So beginning with mild ARDS, just like to highlight that lung protective ventilation strategy per ARDSNet protocols is recommended. Again, using antibiotics if a bacterial infection is present. There's no need to target a blood oxygen content of 100%. Tolerating all the way down to 92% is perfectly fine. As the ARDS progresses in the COVID-19 patient, you may find yourself requiring higher amounts of PEEP. And again, we'd recommend attempting to prone ventilate these patients. In the United States and in some other places throughout the world, they have started using extracorporeal membrane oxygenation, or ECMO, as a rescue therapy. There is no evidence that supports that this is any better than using prone ventilation or paralytics for the patients. So please try to use those as you can. Next slide, please.
For some of these patients, they will have cardiogenic shock and septic shock at the same time. This could either be sepsis-associated cardiomyopathy or a cardiogenic shock specific to COVID-19 infection. Regardless, these patients will have evidence of poor perfusion. So if you're measuring lactate, that will be rising. They will have pooled mottled skin, and then evidence of other organ dysfunction like oliguria or a rising creatinine. This is despite norepinephrine and fluid administration. If you have transthoracic echo available, this could help to show you that your patient has what appears to be a decreased ejection fraction. In these patients, dobutamine is an excellent choice for inotropy and should be your first line agent. This would be preferable to just increasing your norepinephrine dose to very high levels. Advance that slide, please.
Now that we've gone into the cardiac system, the patients that develop cardiac complications are termed to have acute COVID-19 cardiovascular syndrome. This can present itself in two different ways, and sometimes these can present together. The first one is cardiomyopathy. This is generally simply an inflammatory response of the body's own immune system. And this is depicted in the image on the right side of your screen towards the bottom. So as the virus enters the body through the lungs, it can lead to significant hypoxia that results in myocardial injury, and of course that cytokine storm that we referenced earlier. In patients who develop this inflammatory response of cardiomyopathy, we are noting that atrial dysrhythmias are being seen quite often with this. If we look at the flip side of it with myocarditis, and this is the top portion of that image, then these patients are having viral replication directly within the cardiac myocytes, causing direct damage to the heart muscle itself. In these patients, we note that they're frequently having prolonged QT and that they tend to have ventricular dysrhythmias that can lead to cardiac arrest. If a patient has developed this cardiovascular syndrome of COVID-19 and they have existing coronary artery disease, they're of course at a higher risk for increased mortality. This is simply due to a demand mismatch with the need for oxygen to the heart. As this develops, there's a downregulation of the ACE2 receptor throughout the body. This results in an increased amount of inflammatory mediators, specifically the angiotensin II and reactive oxygen species that can worsen this further. Next slide, please.
Fever occurs in almost all COVID-19 patients at some point in their disease, but maybe the presenting symptom in about 40% of patients. For patients with fever, paracetamol or acetaminophen should be used to treat their fever. There's insufficient evidence now to suggest avoiding NSAIDs. So there was early recommendations that NSAIDs should be avoided. The new thoughts are that if you have NSAIDs available and you think they would help your patient, that it is okay to give them. For mechanically ventilated patients with concurrent respiratory failure, antibiotics should be given. We don't have evidence now to suggest which is a superior antibiotic regimen. This therapy should be guided by antibiotics available at your institution and should definitely cover for hospital-acquired pneumonia. Go ahead and advance that slide, please.
We'll move into the next system of the body that we're going to cover here, the neurological system. This is a little different of a presentation than what we're used to seeing, but in a retrospective study out of Wuhan, China, they identified 214 patients with the disease. Of these 214, they classified 126 of them as having a non-severe infection and the remaining as having a severe infection. Of those 214, 36% or 78 patients had neurologic manifestations. So here we'll compare and contrast that severe versus non-severe infection and what neurological symptoms they showed. Some of them had acute cerebrovascular diseases, some of them had impaired consciousness, while others had skeletal muscle injury. Next slide, please. In addition to those clinical manifestations of the neurological system that I just spoke about, these are some of the others that could present in a viral infection, specifically here, seizures, critical illness neuropathy, meningitis, and the others listed. But the most common that you're likely to see in your critically ill patient is delirium. This is just like any other critically ill patient. The coronavirus patients will likely be in your ICU for an extended period of time, only increasing their chance for delirium. We'll talk about that here on this next slide.
Since delirium is so common in this patient population, we thought we'd discuss some ways to prevent and manage it. Here at Vanderbilt, we use the ABCDEF bundle, which you can find more information on from the Society of Critical Care Medicine, but it's basically a guideline for both preventing and treating delirium. I'd like to point out a couple parts of this scale. So the B is for spontaneous awakening and spontaneous breathing trials. So allowing your patient to be off sedation and awake at least once a day and allowing your patient to be on a spontaneous mode of ventilation at least once a day. Certainly, this has to be done in the consideration that if your patient is very hypoxic and unstable, they may not tolerate either of those things. And if you have to use things like paralytics, both of those things would be contraindicated. The other very important part of this for COVID-19 patients is the choice of sedation. Decreasing sedation as early as possible can help to mitigate any delirium. We've found that if we can decrease the sedation on our COVID-19 patients, knowing that they're intubated in our ICU sometimes for a very long time, we can help to manage their delirium. Go ahead and advance that slide. As far as the hepatic system, elevated liver labs are very common in COVID-19 infections, occurring in 14 to 53% of patients. These increases are usually mild, less than 2 times the upper limit of normal, but they are more common in patients with severe COVID-19 disease. The injury to the liver is usually transient and requires no specific treatment, and it could be from the direct virus-induced cytopathic effect, or it could be from immune system-related damage. If you have the ability to measure a serum albumin, this is a marker of disease severity. The histology from patients that have gotten liver biopsies is non-specific, and it's probably not necessary to do a liver biopsy in these patients. Patients with coexisting liver disease are at higher risk for severe COVID-19 infection. Go ahead and advance that slide.
Here we'll move from the GI and hepatic system into the renal system. Just before we get started with the image that you see in front of you, as these COVID-19 patients present to your hospital and you do urine analysis, you'll notice that on admission, some of the studies have identified that albumin is present in the urine 34% of the time on admission. Protein is present 63% of the time, while hematuria is present 26% of the time on admission. So the image in front of you shows that there are 5 different mechanisms, possibly, that can lead to acute kidney injury in these patients, and we'll cover each one specifically here. The first one at the top, hypovolemia, can occur as you're treating a patient who has developed significant hypoxia as a result of the virus. Oftentimes with this significant hypoxia, a patient receives an aggressive diuretic regimen. This induced hypovolemia can result in kidney injury. The next one, ATN, or acute tubular necrosis, is a result of what we think to be the cytokine storm. So all of these inflammatory mediators resulting in direct damage to the kidney. There are a few case reports coming out now of some direct glomerular injury within the nephron. This could also be a result of some of the microthrombi that we're now seeing within the hematological system. So that could be clogging up the glomerulus. In low perfusion or venous congestion etiologies of acute kidney injury, we're seeing this as a result of the cardiogenic shock component of the disease, or this could be due to aggressive ventilator strategies that require high PEEP, leading to a right ventricular failure. So in combination, this can lead to a decreased perfusion pressure of the renal system. Lastly, direct viral infection of the renal epithelium can lead to acute kidney injury as well. Next slide, please. If your patient has developed acute kidney injury, this has been shown to be an independent predictor of mortality. If you do have the ability to perform dialysis at your hospital, there is some evidence to show that it may remove inflammatory cytokines. If this is being used, it's likely to occur in the 2nd week of the infection. Continuous renal replacement therapy is likely better than an intermittent renal replacement therapy, simply due to the cardiac stability for these patients. If your patient presents with coronavirus and has pre-existing kidney disease, you'd certainly want to consider a referral to a hospital that has dialysis capabilities. Next slide, please. This figure shows a compilation of studies throughout the world that together identified 1,211 patients with coronavirus. Of those patients, 11% had acute kidney injury and 5% required renal replacement therapy, So you're very likely to see this occur in your population. Next slide, please.
To move into the hematologic considerations for COVID-19 patients. These patients commonly either present with or have as a complication of their infection pulmonary microthrombi, intravascular coagulopathy, or a microvascular thrombi type picture. They can have resulting myocardial injury, like we discussed previously, and an increase in their cardiac biomarkers. Some labs that may be helpful if available are things like a D-dimer and other signs of kind of coagulation status in these patients, so a PT or a platelet level. Advance that slide, please. An elevated D-dimer in COVID-19 patients is a potential predictor of increased mortality. This data comes from some newer, mostly retrospective analyses that are coming out showing that non-survivors had significantly higher D-dimer levels than survivors. Go ahead and advance that slide, please. For patients with COVID-19 and for patients with COVID-19 and sepsis, low molecular weight heparin or enoxaparin protects against VTE in these patients. For bleeding patients, it's reasonable to keep their platelets, fibrinogen, and PT ratio around the levels that you see here on this slide. Go ahead and advance that slide, please. This slide is an example from our colleagues at Emory University in Atlanta of what they're doing with both the D-dimer levels and these patients that appear very hypercoagulable. So if you have the ability to measure a D-dimer and it's very elevated, even if your patient doesn't have a VTE or you're not concerned about microvascular thrombi, it's reasonable to start some sort of anticoagulation. This varies from institution to institution, but here's an example of the amount of enoxaparin that Emory is starting for these patients. If you think your patient has a PE or a DVT, or you think that they have some evidence of microvascular thrombosis, so we're seeing patients with black fingers and toes, probably from microvascular thrombi in their digits, these patients should absolutely be anticoagulated with either enoxaparin at therapeutic doses or a heparin infusion, whatever is available at your institution. Go ahead and advance that slide, please.
This ends our slides that have discussed all of the current literature on the subject. At this point, we're going to transition to what we've learned specifically here at Vanderbilt Medical Center. We know that supportive care is what is currently recommended from the surviving sepsis guidelines for our critically ill patients. Specifically, we talked about how the sepsis and shock state can be treated, and I saw that there are a couple of questions that have come up already about that, so I'll just address those briefly here since they are recommended by the surviving sepsis guidelines. Norepinephrine is the preferred first-line agent, simply due to typically its availability as well as its ability to provide inotropy and vasopressor support. The other question that came up was why crystalloids over colloids. The surviving sepsis guidelines show that colloids are no better than crystalloids and are typically more expensive, harder to come by, and some of those colloids, specifically dextrans, can actually result in renal injury. At Vanderbilt, we've developed some different personal protective equipment guidelines specifically for staff and families. These are available on the website and we can make those available to you. They go over exposure for staff, exposure for families, how to perform aerosolizing procedures if necessary, as well as environmental cleaning. ICU admission guidelines are something you're likely familiar with, but the Society of Critical Care Medicine recently came out with information that shows that these guidelines may result in us making tough decisions. We're all familiar with this. They have 3 groups that they've identified. One group is a group of patients that would ideally benefit from an ICU environment. Others may simply be too sick to come to the intensive care unit and should have end-of-life discussions initiated, while the third group, for them, is fortunate, may be too well to come into the intensive care unit. Next, I'd like to discuss CPR. At Vanderbilt, we've established a specific team that responds to cardiac arrests in coronavirus patients. This is important because, as we know, the virus is highly infective. So there are a limited amount of people that are allowed into this patient's room during a cardiac arrest event. A team leader, someone responsible for the airway, a respiratory therapist, and 2 individuals to perform compressions and administer medications. Outside of the patient's room, we have what we've deemed a safety officer to watch for the appropriate placement on of personal protective equipment, as well as the appropriate removal of that PPE. There's additionally other folks that are present outside of the room that run the code cart, get medications, and record the event. We'd like you to be aware that there's a possible need for a very high amount of PEEP in these patients. They do benefit from proning, so be familiar with how to prone position a patient who is ventilated. While we iterated earlier that sedation should be minimized in the patients, if you're having to administer a high amount of sedation, specifically propofol, just be aware that this could lead to a propofol infusion syndrome. And lastly, as the clinical picture presents itself, these patients may have a much higher amount of hypoxia than you'd anticipate. And with that, we'll move on to the next slide, which is simply questions. The last 2 slides are the references for the material that we showed here today.
Thank you so much, doctors, for this wonderful presentation. We've been getting a lot of questions in the chat. We also got some questions earlier, and I'm going and keep asking your questions, please, in the chat if you have them. And I'm going to turn this over now to my colleague, Monica, to facilitate the question and answer session.
Thank you so much. And again, thank you for your presentations. So I'll just start asking questions. It's similar to last night in the sense that any of the doctors on this call, please feel free to respond. They are for all of you. Just going back a little bit to sepsis, I know we talked about this, but how there are quite a number of questions coming in on how to manage a patient with sepsis secondary to COVID. How does septic shock occur, and how do we recognize this and treat this?
So kind of cutting it down to the very basics, we define sepsis as the body's response to an infection, but it's an abnormal response. That there are a number of physiologic and biologic changes that occur as the body is responding to this infection, that the upregulation of inflammatory biomarkers can cause. And the things that we see in people with sepsis are low blood pressure. Sometimes they also have decreased cardiac output. There's an effect on the heart from the sepsis. And then they may have other signs of end organ dysfunction. So they develop this kidney injury, liver injury. They may have the neurologic changes that we talked about. So all of that body's abnormal response to this infection is sepsis. Septic shock is when you have a patient who has low blood pressure that is refractory to basic interventions or fluid management. So you'll recognize these patients when they come in because they will have a lot of the symptoms that we talked about earlier, where their blood pressure will be low. They may have very warm skin, or they may be very cold and clammy. They may have a very high heart rate. Oftentimes they will have low oxygen levels. And they may not be making as much urine as they normally should, showing you that there are signs of damage in the body. And so then in order to treat that, the first step in treating sepsis from the surviving sepsis guidelines is to give fluid back to patients. And that's where we suggest using those dynamic measurements of fluid. If you have a patient who's laying down and you raise their legs up at about a 45-degree angle, if their blood pressure gets better, as Dr. Brennan talked about earlier, then they will likely respond to a fluid bolus, and that's a good place to start. If they are not responding to that, or if you've given, if you've tried a liter or two of fluid and their oxygen levels are getting worse and their blood pressure is not responding, then that's a great time to add the vasopressors in.
Thank you. A few questions coming in about cannula use. One of the materials shared on the WhatsApp group, I guess beforehand, discouraged high flow nasal cannula use because of aerosol generation. This is a little bit different from what Dr. Bruns had presented. Could you please clarify this?
So early on here at Vanderbilt as well, we were avoiding high flow nasal cannula and also non-invasive positive pressure ventilation BiPAP or CPAP, with the concern that those high volumes or high flows of air and that high pressure will then aerosolize the virus into the air and cause a higher risk for the providers. That has been balanced against a concern for preserving ventilators and avoiding having too many patients intubated at the same time, and also that there is a thought that there will be less lung injury or less progression of the lung injury if you avoid positive pressure ventilation. So we are now actually, we have now sort of gone back and rescinded that avoidance of high flow nasal cannula, and we will place patients on high flow nasal cannula and place a mask over them, and then of course recommend that everyone else in the room wears appropriate PPE, recognizing there is some risk of aerosolization, but that some patients are actually doing better because they don't sustain any lung injury from the positive pressure ventilation.
Okay, thank you for clarifying that. And in regards to that as well, are nasal prongs for high flow nasal cannula use the same as usual nasal prongs or different? And also, what about BiPAP in the sense of high flow nasal HFLN and spreading of the droplets?
So high flow nasal cannulas are different. There are various forms of high flow nasal cannulas. Some will support up to 15 liters of flow delivery. Others are a completely different system. At Vanderbilt, we use one called the OptiFlow system that will deliver up to 60 liters of oxygen at a time and may not always be available depending on where you are. But I think one of the really important takeaways from what we're starting to see now is that the longer we can leave patients on supplemental oxygen without having to move to the ventilator, the better they seem to do. And so two strategies for that are to, or I guess three strategies are to increase the oxygen delivery as much as you can through supplemental measures, to allow those patients who don't have a breathing tube in to be positioned on their abdomen for as long during the day as they can tolerate, up to 16 hours a day in that prone position, to improve the distribution of blood flow and oxygenation. And then hopefully to kind of avoid and then to tolerate lower levels of oxygen. So they certainly will not have a blood oxygen saturation of 100%, but that's okay.
Thank you. And one final question on that: how can we adapt regular nasal cannula to use for a higher flow nasal cannula?
I'll take that. I don't think there's really a way to do that, because the higher flow nasal cannulas because of the amount of flow that you can offer some PEEP. I think because the Society of Critical Care Medicine and the data is kind of showing better outcomes. With that, what we're suggesting is decrease your amount of sedation, leave the patients not intubated as much as possible by using higher flow oxygen and whatever you have available. Of course, be careful because, you know, like someone raised in the chat questions, there will be aerosolization. So put a mask on the patient, put a mask on everyone else who's around them to try and minimize that as much as possible. But because the outcomes are better, the society and the critical care groups are all trying to do less of mechanical ventilation.
Thank you. Moving on to a different topic, can we treat COVID patients without central lines if we don't have any?
I can take that one. Yes, definitely. If you either don't have a central line available or there's no one that's very comfortable in inserting central lines, it's preferable to just do what you are comfortable with at your institution. If you normally use vasopressors through peripheral IVs, this is fine to do for COVID patients and would be preferable than having someone who's not familiar with inserting a central line try to insert a central line. As we mentioned previously, using a large IV cannula and trying to get it either in the elbow or a little bit higher, just to make sure it's reliably in a vein, is a fine thing to do.
Thank you very much. Oh, go
Just
ahead.
to follow up on that, one of the key things I think we were trying to point out is try and not use your vasopressor line if possible for your other infusions. So keep your vasopressor line separate and try and do your volume resuscitation, antibiotics, and anything else that you're doing through another IV again if possible.
Thank you. What are the outcomes of acute kidney injury in patients after dialysis? And how do you, or are there ways to avoid causing AKI in a septic ARDS patient if you need to limit the fluids and give vasopressors?
I can take that as I discussed the renal system earlier. In patients who have developed sepsis, ARDS, ways to try and avoid acute kidney injury in these patients would be to look at those etiologies that were mentioned on the figure earlier and simply try to avoid those. So this means using vasopressors and using fluids as necessary to achieve a higher mean arterial pressure, at least 60, as well as at the same time ensuring that their cardiac function is appropriate so that the backflow or the venous congestion doesn't become too much, so they have an adequate amount of perfusion pressure to the kidney. In the first part of that question, I think, can you repeat that one more time?
The first part was just what are the general outcomes of AKI patients after dialysis?
Yeah, so this is something that's still evolving, and I don't believe we currently have data on this, but treating patients who have acute kidney injury typically begins with diuretics, observation, monitoring their urine output. There's no need necessarily for regular intervals of laboratory measurements. If it progresses to a renal replacement therapy, then those patients that are on dialysis, certainly it's possible, just as in any other critically ill patient, that their kidneys can recover once the cytokine storm of the coronavirus begins to dissipate. Now, the actual numbers on this are still pending.
That's great, thank you. Since paralytics are not generally advisable, is it advisable to use a higher dose of a sedative? And also, is there an agent that is more preferable?
Paralytics are something that we reserve as kind of a last resort, so to speak. And so if you don't have access to a paralytic, If you need to go up on a sedative, that's fine, but we would again try to avoid high levels of sedation, as it's best that patients that are ventilated or not mechanically ventilated are proning themselves and also initiating some of their own breaths to attempt to avoid ventilator-induced lung injury. If it becomes apparent that they've reached a point where they're too dysynchronous with the ventilator and a paralytic is unavailable at your institution, then certainly higher levels of sedation are appropriate at that point. And there's no preferred agent for one over the other, as there's a lot of shortages at this time. However, typically we try to avoid benzodiazepines in the critically ill population.
I think one of the key takes is that, go ahead, Kimberly. One of the key takes is that we want to avoid sedation as much as possible, and mechanically ventilated patients do not always need to be sedated. We will oftentimes have patients on mechanical ventilation at our institution who are on minimal sedation, writing on a piece of paper, actually communicating with us. So that's kind of what we are advocating, which is the reasoning for doing these spontaneous awakening trials and spontaneous breathing trials daily, so you can take that breathing tube out as soon as they don't need it.
And in follow-up to that, I'm sure this sort of goes without saying, but if you do reach a point where you have paralytic available and you are able to use it for, and you need to use it for a patient, then that targeting light sedation, of course, goes out the window, and you want to keep them well sedated so that they don't remember having the paralytic on board and being awake. So we do go with deeper levels of sedation once a paralytic is required. And then as soon as the paralytic wears off, that's when we lighten up that sedation and try for those awakening trials every day and the breathing trials every day.
That's great, thank you. Just going back to more questions have come in on AKI. Can you speak a little bit about fluid management in COVID-19 patients who have AKI and hyperglycemia?
So if you've reached a point where you're needing to administer fluids to patients who have COVID, they're likely in or possibly in a shock state. So giving them fluids is certainly preferable to not giving them fluids and allowing the shock to become worse and that acute kidney injury to become worse. So that's the first part of that question. We want to make sure that we're giving enough fluids to allow a higher perfusion pressure of the kidneys to deter acute kidney injury. I think that should help.
And we sort of talked about this last night as well, but I think this is one of the great questions that we face in critical care. Does a patient with low blood pressure who's showing shock need more fluid, or do they need a vasopressor? And I think that's when it's really important to employ those dynamic measurement techniques that we talked about, where if you're giving some fluid, absolutely there are patients that will come in with COVID who have had fever at home, who've had a decreased appetite, who may have had nausea, vomiting, diarrhea, and they need more fluid. And what's important is if they're responding to the fluid, if their blood pressure gets better and their oxygen isn't getting significantly worse, then fluid is the appropriate strategy. And once you reach a point where patients are no longer responding to fluid therapy, their blood pressure is still low, and perhaps their oxygen is getting worse because their lungs are filling with fluid, then vasopressors are important. So we definitely want to balance the two, and just also recognize that the kidney injury can occur because the patients have hypovolemia when they present, but there are also those other mechanisms of kidney injury, and fluid will not always be the answer for that, for decreased urine output and for kidney injury.
Thank you. Just a few questions on CPR here. Can you speak a little bit to how to perform it while observing IPC measures? And also, what is the survival rate generally after CPR?
Thank you for that question. So that was something that I should have mentioned when we were discussing CPR. It's the same as you would for any other patient with a few key caveats. The first being compressions are the first go-to thing to do. And while doing this, you should place a mask over the patient's mouth to attempt to limit the amount of aerosolized virus particles. Holding compressions during intubation is advisable, whereas typically we would not do that. The reason for this is, again, attempting to limit the amount of aerosolized virus. And the other thing is, once the patient is intubated, clamp the endotracheal tube, if you have a clamp available, prior to hooking them up to the ventilator while you confirm that it's in the correct place. Other things, again, is simply maintaining a limited amount of people in the room during that event. And then the actual numbers right now are still pending as far as the outcomes after CPR. And we really think that if a patient has reached a point of cardiac arrest with their coronavirus, CPR may really be futile, but we don't have the numbers to show that just yet.
Thank you. And just building on that a little bit, if HMEF, and I'm sorry, I don't know what that stands for, or viral filters are not available, would you still recommend ventilating patients while the risk of spreading infection is high?
I think if you don't have, certainly it's optimal to use a viral filter. If you don't have one, I think using what you have is important. So if you don't have the viral filter available, extra caution to avoiding disconnections in the ventilator. So I saw there was another question about suctioning. Ideally, again, inline suctioning, anything where you don't have to disconnect the ventilator from the circuit is preferable. But really, if you can't do that, realizing that that is a potential for aerosolization, and if you have PPE that would be appropriate for that situation available, certainly have all of your staff members in the room wear it. And again, like Dr. Bruns mentioned, minimize the amount of people in the room during those procedures.
Great. I'm just going to try to ask one or two more questions, noting that we're almost out of time. Maybe just one. There are a lot that have come in, and we'll try to answer them all post-session. Most cannot measure D-dimer in low and middle income countries. What clinical tools can we use to diagnose thrombosis? Can you just put blood into a tube and see when it forms a clot? Too fast or too slow?
So I think that the important takeaway from this is that your clinical suspicion for clot should be very low in these patients. And as soon as you suspect clot formation, then you should start them on some form of anticoagulation. And the clinical signs that you can look for are the common signs of a deep vein thrombus, like swelling in one of the extremities, or pain tenderness in like the calves or the upper extremities. Or as Dr. I think Brennan mentioned, one manifestation that we're commonly seeing in COVID are these blackening of the toes and the fingertips, where you're seeing the tissue start to necrose because you're having microthrombi. And so as soon as you start to see those types of signs presenting in your patients, there's concern that you're developing clot throughout the body and that you should be giving higher levels of anticoagulation.
Thank you. As I mentioned, there were a lot of questions that came in we were not able to address. My colleague Claire will shortly talk about a WhatsApp group that we will hopefully use to address some additional questions, but I'd like to give a last word to all of the doctors on the call today who gave these great presentations. So Dr. Banerjee, would you like to start?
Thank you so much for asking us to speak. And I'd first off like to say, be safe out there. We're all in this together. There are a lot of Society of Critical Care Medicine guidelines that are free resource that are available on their website that you can access. And those will give you an overview of sepsis and septic shock. There's some good videos that they've made available, which are some of their lectures that they generally do. So feel free to go on their website and access those if you can.
Thank you very much. Dr. Bruns? Oh, I think you're still muted.
Sorry. Just like to echo what Dr. Banerjee said, you're not in this fight against coronavirus alone. There's lots of critical care experts out there that can provide guidance. There's lots of materials to go through. And again, referencing the Society of Critical Care Medicine can provide a lot of help for that. Lastly, we'd also like to thank Project ECHO and Assist International for helping us share this information.
Thank you. Dr. Brennan?
Just to echo what has been previously said, thank you for all the amazing questions. They're really great. And I know this amount of information can be very overwhelming and coming from many different sources. What we found here and what our colleagues have found throughout the US is going back to the basics of critical care and the basics of sepsis management is really helpful in these patients as well as all of your septic patients. So there are some differences, but there are a lot of similarities as well.
Thank you. And Dr. Rengel?
Thank you all for your active participation, your excellent questions, and thank you for the opportunity to present this information. I think my colleagues have really covered a lot of our sentiments, but just that we're all in this together. We're all learning together every day, and we do know that things change every day. But like Dr. Brennan said, when in doubt, sticking with what you know and how you would normally care for patients is often the right answer. There, are of course a few differences that we've tried to highlight here, but going back to what you know best and how you would normally care for patients is always a great option when you're not quite sure what to do. So stay safe out there, and thank you all for your time.
Thank you all again so much. And I'm going to pass this back along to my colleagues, Chase and Claire, to close out the session.
Yes, so thank you all for your questions. We know there are more questions out there. So we have established a WhatsApp group for the entire series. And you can join this WhatsApp group and help us keep the discussion going. Submit your questions there. You can join the group by scanning this QR code that you see on your screen with your cell phone. We'll also be sending out a link to your emails. And you can also reach out to us via email at echo@assistinternational.org. Thank you.
Thank you. And now we're going to put up, and again, what a wonderful presentation. And I want to thank all of the presenters as well as the participants who joined us, our interpreter for interpreting. We really appreciate it, and Vanderbilt for offering this wonderful lecture series. We do have a short poll that we'd like to put up right now and have you guys fill out, if you would, before you leave us. It helps us to understand who's attending and how we might better tailor the lecture series to what is critical for you at the moment. And so Chase is going to be putting that poll up right now. And then again, please join the WhatsApp chat group. We will be giving you the slides via an email as well as a link to this recording. And again, we just appreciate everyone who participated, all of the presenters. Thank you so much. This is fantastic. And if you have suggestions on what you'd like us to see and topics you'd like us to cover, you can contact us, please, and let us know. Thank you very much.
We're going to leave the poll open for just a little bit longer. So if you're still finishing that up, please take a little bit of time to do that. Thank you. Thank you, everybody. It looks as if everybody has taken the poll. We appreciate you doing that for us, and we look forward to seeing you here again on Friday. Thanks, everybody. Bye.
Thank you.
Thank you.
Thanks, guys.
Thank you.
Thank you, guys.